So, let's start out with a case. So you're going to work through this with me. This was a 70-year-old woman who had been noticing the onset of double vision for the last 2 to 3 months. And first it was a little bit horizontal and then it became vertical. And as you can see in primary gaze, it's not obvious that there's a misalignment. I'm going to show you a 9 cardinal gaze picture, and then we're going to work through that. So let's first take one at a time. How about in left gaze? Do you think that they're in alignment, or is there any weakness? Which? Yes, so you can see some scleral show here. And so if you compare this adducting eye with this adducting eye, there's a weakness of adduction. How about infraduction? How's that look? So you're looking at the limbus. That looks pretty good, doesn't it? Nothing obvious. And how about superduction? So superduction, that right eye just doesn't get up as high as the left eye. And then how about in left gaze? A little bit of abduction deficit. So how would you put all that together?
It doesn't look like it doesn't fit.
Yeah, it doesn't fit. Why? Well, I mean, you've got an adduction deficit and you've got a superduction deficit, but what doesn't fit? Okay, so maybe it's maybe you could say it's a third and a sixth, but is it a third even?
No.
Why? Well, I mean, tell me why. I agree with you.
Down gaze and ptosis.
Right, so you don't have any ptosis, and you don't have any infraduction deficit. And one kind of rule that I've never seen broken maybe once in a great while is that in the divisions of the third nerve within the division, so let's say the inferior division, you can't affect one muscle in the division and not the other. So this is an example of that. On the inferior division, how can you have an adduction deficit but have normal infraduction? That's in the same division. And from the superior division, how can you have an up gaze problem but not have any ptosis? So that's very hard to do in terms of pathology. So it doesn't fit, right? So she had a fundus exam, and that's what was found in the right eye. So she had a big choroidal mass, and it turns out she had, unfortunately, metastatic breast cancer, and the mets were to some of the muscles. So yes, it's an electron third nerve palsy, but not everything in electron third nerve palsy is third nerve. So you guys are very sharp. Good. Here's a woman who had a history. She was 85, and her family brought her in. She actually didn't notice any problem, except that, as you can see, the lid had gradually come down over the last year. And when you lifted the eyelid up, this is what you saw. Here's the 9 cardinal gazes. So let's go through this. So first, obviously, in up gaze, she doesn't get the eye out. Right? How about in down gaze? Looks pretty good. And how about if you compare adduction here compared to adduction there? Looks pretty good. So everything looks good except she's got a profound ptosis and she doesn't get the eye up past the midline. So how would you put that together?
That could be the inferior branch of the oculomotoris nerve.
Which branch?
Sorry, superior.
Superior branch,
Yeah.
right.
Mm-hmm.
So you're looking for a superior branch. And then She had a pacemaker and didn't get an MRI scan, and she had a CT scan. So do you see anything abnormal on that CT scan? Very good. So most common cause of a progressive cranial nerve palsy in an 85-year-old would be a meningioma. And there's something here that shouldn't be there. And if you look at the bone window, there's some calcification. So she had a slow-growing meningioma there. It's very good. We're going to get a little bit harder. This child got his finger stuck in his nose. Got double vision. And the story wasn't exactly clear. The parents brought the child in, and they noticed something was wrong. But the child wasn't really saying anything, when it happened. So let's see how much you can get out of just one photograph. Well, first of all, how about the lids? Lids look pretty normal, right? So the eye position is exotropic, and I can assure you that this patient did not have any mydriatic drops. And the eye is not only exotropic, but what other position is it in? Hypertropic. Correct, hypertropic. So just from that one photo, you've got a squirrely kid that can't sit still. How would you put this one together?
It's out, but not down.
Right, can't get the eye down. Let's see if I've got one more picture. So you can see still that eye doesn't go down, and it's out. But there's really not much effect on the lid. So now you're thinking about an inferior division, third. So we pushed a little bit harder about the history, and he and his friend were out in the yard playing, and they were playing, swords and sticks. And the friend lunged towards him, and when we pulled down the conjunctiva, the lid, there was an entry. And so he picked off his inferior division right in the orbit, like a skewer. So there's an example of a pure inferior division third from a peripheral injury, right, trauma. All right. This is an interesting case. This woman had come in about 6 weeks before to the comprehensive ophthalmology clinic because of complaints of trouble reading. And she was found to have an exotropia and was diagnosed as having a convergence insufficiency. And that was the cause of the reading. And given some exercises, and she came back 6 weeks later. And part of the reason she came back is the double vision had gotten worse. And her neighbors were concerned that she was drinking alcohol because she was kind of walking funny and started talking funny. And there was some concern that she was drinking too much alcohol. And so I'm going to show you some photographs of her. So here's the 9 cardinal gazes. Let's try to put that together. Let's go up first. So how about in up gaze? It looks pretty normal. And how about in down gaze? Right, if you draw a horizontal line across there, the limbus is not in the same place, is it? So some introduction problem. And then on the left side, let's compare adduction of the right eye with adduction of the left eye. So you don't see really sclera, but let's just compare adducting versus adducting. What do you think about that?
It's more adduction.
Right, this eye adducts better than that eye. So you're picking up on the subtle things now. So she's got an introduction deficit, adduction deficit, no ptosis and no upgaze. And how about the pupils? Can you tell anything from these photographs about the pupils? Kind of small. Let's, I've got a greater view. Yeah. As a matter of fact, now that you've had the pupil lecture, how would you pick up subtle pupil involvement? So you're looking for sphincter involvement, right? So that's from the parasympathetic that's running along with third. What's the best way to bring out a subtle efferent defect based on what we talked about yesterday? What would you do in the light?
Within the light.
Bright light, exactly. And because not everyone's going to be a blown pupil, it's going to be a relative. And remember, the other motility wasn't complete either. It was very incomplete. So put that all together. Let me show you, back then, this was one of the first computerized pupilometers. What are we showing here? Here's a light stimulus, and showing the right and left pupil, and this is showing the anisocoria, the difference between the two. So what are you observing at the peak of contraction? That's like you're adding a bunch of light in the room. What is that showing? So this is the left pupil, and this is the right pupil. So the anisocoria is getting greater at the peak of contraction. So that's further evidence for a weakness of the sphincter muscle. Okay, so let's put the motility in. We had no ptosis and normal superduction. We had an adduction deficit, an infraduction deficit, and pupil involved. So it's inferior division third. Where do you think the lesion is? Remember the anatomy that you had one of the first lectures? Well, I'm not talking about the cause. I'm talking about the where would it be located in terms of anatomically? Do you know where the third nerve divides into a superior and inferior gland?
In the orbit,
Kind of right in the rostral cavernous sinus orbit. So that's where you're thinking the lesion is. But what were those other symptoms I said that her neighbors were coach walking kind of right and walking right? Can you put that together with this lesion? Hard to do that if you're pushing yourself towards the orbit, isn't it? We'll come back to it. So this was quite a while ago. As you can see, the quality's not as good as it is today, but here's a mid-sagittal section, here's an axial section. Anything that looks unusual or not where it's supposed to be?
Something in the middle.
Yeah, what the heck is that? What, this thing? Huh? What is that? And looks like that's the same thing there. Very good. So that was a basilar artery aneurysm. Now you're wondering, well, how can she get an inferior division third if she has a basilar artery aneurysm? Because we said anatomically, if you look at cadavers, the third nerve divides, in the orbit, but this is back further. And this is an important point, is that the fascicle, here's the third nerve nucleus, and you've got all these axons coming through the brainstem, the midbrain, before it exits, the subarachnoid space out of the brainstem. And the important thing that's a number of papers been published is that the topography of these divisions are made within the fascicle within the brainstem. So just because the nerve anatomically divides into two divisions in the orbit, that topography is preserved way back in the brainstem. So you can have all kinds of pathology in the brainstem and get a divisional third. Okay, that's the point. And those other symptoms were in the other neural pathways that are running, you know, remember what structures are there in terms of the red nucleus and the control and coordination and speech. So here's an example of, you know, don't ignore other symptoms that seem to coincide in time with ocular symptoms because they may come together to help you localize. Yeah? I've seen a lot of frowns. This was an inpatient we were called to see. And she was having all kinds of problems, and one of them was this. And she was also having trouble seeing, too, even when we lifted the eyelid. I'm going to show you some 9 cardinal gazes. But take a good look at this picture, and then we'll go to the 9 cardinal gazes. Or here's, couldn't get 9, so here's right and left and up and down. So let's, first of all, obviously in right gaze, what you see? There's a complete adduction deficit. And in left gaze, pretty normal. And she couldn't quite look down for us, but I would say the limbus looks like maybe that limbus isn't quite as low as that one, so maybe a little bit of introduction. And how about superduction?
It's like the face.
Yeah. Do you think it's limited in one eye or both eyes? And how about the eyelid? Yeah. So it's easy to ignore the right eye because it doesn't seem to be affected as much. But now that you're looking at it, so where would a problem be that would affect, you know, one eye more than the other, but both eyes? And how come it's only affecting in the right eye? It's affecting the lid and kind of the superior division. That's harder. It has to be somewhere where the two oculomotor nerve nuclei are located, right? And then we found this on exam. Yes, she had endocarditis. And this was her scan. So first of all, you can see in the midbrain, you know, right, just ventral to the aqueduct, right where the third nerve nuclei are. And then there were also, her vision problems were not only in the occipital cortex, but she had a branch retinal artery occlusion in one eye. So here's an example, you don't see them very often, of a nuclear third. And why am I bringing up a nuclear third? Because if you remember that anatomy of the nuclei, is that first of all, the levator subnucleus is dorsal. And it's hard to affect one and not the other. They're almost united. So a nuclear third often gives bilateral ptosis. It could be asymmetric. And then remember the superior rectus subnuclei cross. So it's easy to get both of those involved. That's why she had an up-gaze problem in both eyes. And then the other subnuclei were more in the left. So these often have a mixed pattern. The pupils can be involved too. And so if you see both eyes involved, and it looks patchy like that in terms of the other eyes, mainly lid and superduction, think about the nuclear third.
Can you show the lesion in the brainstem?
Yeah. So I think this laser is working. Oh, here it is. So here's the aqueduct, this dark thing. And you've got a bright signal right here. That's where the nuclei are located. Okay?
Yeah.
This was a man we were called to see in the hospital because the neurologists were sure he had myasthenia because he couldn't open either eye. And here was his motility. So actually, adduction looks pretty good in each eye, right? And superduction, not so hot, but pretty symmetric. And down gaze looks pretty normal. He had almost complete ptosis. And they had already given him tensilon without any effect. And they were a little puzzled, that's why they called. Also, what you might not appreciate very much is his pupils were fairly small. And even in dim light, they were small. We'll come back to that in a second. So the question is there any place that you could give a lesion that would affect both eyelids, but not really motility that much? So when we talked about where these subnuclei roughly are located, and I'll show you what the scan looked like. It was called normal originally. So you're in the brainstem because here's Mickey Mouse. But Mickey Mouse has a lot of lipstick. And so there's this is the aqueduct, there's periaqueductal brightness there. And remember, this is again getting into where the levator subnuclei are. And he had a lymphoma that was infiltrating the area. Now, why were the pupils small? We didn't get a chance to talk about this in the pupil lecture. We did a little bit, but what controls your pupil size when you're awake? I mean, the pupils are about mid-size when you're awake. Do you know what happens when you start to go to sleep? What pupils do? No, actually they constrict. Same thing, have you done a rotation in anesthesia before you started your ophthalmology residency? So remember, when someone goes under general anesthesia, their pupils get small. And anesthesiologists use that to monitor the degree of anesthesia. And then if you give narcotics, the pupils get small. So the question is, why with getting sleepy, why with narcotics, why with anesthesia, the pupils get small? So the Edinger-Westphal nucleus is an interesting group of neurons, because unlike other parts of the brain, if you take away all supply to them, all innervation, they fire like crazy all the time. And so if you took away anything that innervates them, they're firing and the pupils will be small. And what makes your pupils mid-size? There are ascending fibers from the reticular active vein formation and locus coeruleus that normally inhibit the Edinger-Westphal nuclei. So it's constantly being inhibited some, which keeps your pupils at mid-size. And when you give a light to make them constrict, you have to overcome that inhibition. And so when you start to go to sleep, that inhibition starts fading away and your pupils get small. When you put somebody under general anesthesia, that inhibition starts falling away and the pupils get small. And the same thing with narcotics. And those fibers, as they travel upwards, they travel along the periaqueductal grade. So anything that affects this area is going to take away that inhibition. The pupils will be very small. So it's a nice little pearl to remember. Besides drugs, like narcotics, and besides, someone being asleep, it's not normal for a person's pupils to be that small. They're still reactive to light. They're just very small, even in darkness. Yes?
Can you repeat once? When the nucleus are, is it sympathetic?
So those nuclei are preganglionic parasympathetic, right? So those Edinger-Westphal nuclei are the preganglionic parasympathetic neurons. But it turns out those inhibitory pathways are central sympathetics. Yeah, that inhibit them. And we didn't talk about physiologic anisocoria, because that's the most common type of anisocoria. We talked about 80s. We talked about Horner's. But we didn't talk about physiologic anisocoria. Physiologic anisocoria is thought to be due to, at that moment in time, asymmetric inhibition, which is very common. And that asymmetry can switch. So physiologic anisocoria, one of the hallmarks, is that it may come and go, or it may switch eyes, which is the larger pupil. And because it's this asymmetric inhibition, what maneuver would you do in the lane to overcome that asymmetric inhibition? What condition would you do to get rid of the anisocoria? So you have to do something that's going to take away the inhibition, besides putting the patient to sleep.
Shining light?
Really, yes, bright light, or a strong near response, because it has to overcome the inhibition too. And that's why also these patients, they come in concerned because they notice it. It's usually they notice it more in dim light, the anisocoria. If we took everybody in this room right now and took pictures, and Byron Lamb from the US did this when he was a resident at our institution, about, at any given time, a just noticeable anisocoria, which is about 0.3 millimeter difference, you can see with your naked eye. About 20% of people right now, 1 out of 5 of you will have a noticeable anisocoria. So if you look deep into the eyes of your neighbor, you might see an unequal pupil right now. And about 5% always have it in the same eye. But the other ones, it just switches and comes and goes. It's kind of interesting. So we were talking about localizing this, and here's the aqueduct, here's the subnuclei, and then these periaqueductal gray fibers are inhibiting the Edinger Westphal. You can see the Lieberger fibers are right here, right adjacent to the aqueduct. Okay. We already had this case. We didn't show the imaging. So this was...
So, did you do the right influence for the previous cases?
yes, they should be on the PDF. Yes.
Comments.
Comments?
For the cases.
Maybe not.
Maybe not.
This case we already saw yesterday, and we have the video. Remember, it was on the differential diagnosis of an acute, painful pupil involving third. And remember, just to review, the one that everybody says first is aneurysms. Toulouse Hunt, we talked about. Rarely ischemic third can involve pupil. Ophthalmoplegic migraine, giant cell, wide eye, and then this one. Remember, that was number 2, which is the pituitary apoplexy. So we have that case. And remember what we were talking about pituitary apoplexy on the pupil lecture is that if the ischemic pituitary tumor that suddenly expands from edema and or hemorrhage, if it expands laterally, it's going to hit one or both of the third nerves. If it expands upwards, of course, you're going to get visual field defects. Once in a while, it'll be both. If you get a patient with one or more third nerve and visual field loss and pain and pupils involved, think about this one. Okay, this was an interesting case. Well, you didn't take a look at it yesterday. Really?
2 weeks ago, she had a bad headache, and then about 20 days afterwards, she started to notice the problem. 4 days later, she started to have some double vision, and also pupil was already a little bit bigger, it got bigger. And she's been having last episode she had this was 93. But probably the first episode was age 7. It was happening every year, but it hasn't come on since then. So here's a moonlight, and here's adding more light, makes the difference in people's size even greater. I should be after that, I'm not really going to anything. And then I'm going to have you, this will be behind you, I'm going to have you look over to the right, and up and right, straight straight up high. And up and left. And straight over to the left. And down and left. Keep looking down left and hold up the leg for just a second. And straight down. Down and left. And straight ahead now. And then look down. Down and right. Down and left. Down and left. So that leg does come up a little bit on the left.
I don't know if you heard what I just said. I'll repeat it. So she had a history of repeated episodes that started early in life. And it seemed to come on right at the end of a bad headache. And as a matter of fact, she was dying in the emergency room as a child and had all kinds of imaging. So, does that ring bells at all? Right, so
Everything else is
she had repeated third nerve palsies. And some of them were people involving, as this one is. And some of them would resolve completely, some there's a little bit of residual. And she had an MRA, which was completely normal. And this was her imaging, or tissue imaging. So remember, this is her right third. So do you see anything there that looks abnormal? Yes, there. And here's it in coronal. And the interesting thing about it is she had repeated imaging and has continued to enhance with dye, which is characteristic of this phenomenon. That no, it's not demyelination, because that doesn't it rarely affects cranial nerve. And it wouldn't continue to enhance like that. So this is what people coined the term ophthalmoplegic migraine. Although nowadays people don't think it's really true migraine, because why do you get enhancement of the third nerve? And but that term has stuck. And it's not completely clear. I think, Nancy, you had a case you found a long time ago that you thought was a bleeding hemangioma or something in the nerve,
Correct.
didn't you?
Or a schwannoma.
Yeah, schwannoma. But most of these probably aren't schwannomas. I don't know. Do you?
I think they are.
You think they are?
actually.
Okay.
I think they are. The one that we have pathology on was actually a hemangioma. But I think they're benign tumors like we see with the trochlear nerve.
What's interesting is a lot of them recover.
Right.
Some of them recover partially. So, so the important part about this is that the history of repeated episodes and this funny enhancement of the nerve that often stays enhancing. It's not just during the time they have the acute episode. So you're going to probably encounter this, and of course people get all excited when a 5-year-old comes in, with the first episode, because you work them up thoroughly, you're thinking there's something bad going on. So any other comments?
But you just said that MS doesn't involve cranial nerves.
Rarely, very rarely.
What about the visual nerve?
Optic nerve.
Yeah, optic nerve.
These patients don't have any optic nerve problem.
No, but with optic neuritis.
Oh, sure. But I mean, demyelination can, rarely affect cranial nerves, but that's a very unusual presentation of demyelination.
But when I read anatomy, the optic nerve is a cranial nerve.
Oh, I'm sorry, I meant motor cranial nerves. Thank you. Yeah, you're absolutely right. Okay, we already saw this case. This was the boo-boo that I made, almost 40 years ago. It didn't have anything but a dilated pupil, and then a month later had a third nerve that went along with it. Remember, that was the aneurysm case. And we talked about this, but here's what I wanted to show you, which we didn't talk about yesterday. We mentioned it, but if you look at sections through the third nerve, and these are labeling studies that were done, this black is the location of the pupillary fibers at different locations. So once you get into this area where the posterior communicating artery aneurysms are usually located, the accommodative and pupil fibers, remember we said, is on the medial side of the nerve. And that's why things that compress the third nerve from the medial side, whether it's a pituitary apoplexy or if it's an aneurysm, commonly affect pupil and accommodative fibers, and sometimes that's the first thing that's affected. So just kind of tattoo that into your brain in terms of where those are located. That helps you think about mechanisms.
Which that part of the pupil, is that what you're saying?
That part of the third nerve is topographically, that's where the pupil and accommodative fibers run. Yeah, very good. Here's a man that came in with a complete ptosis and a little bit of pain. And doesn't really look like there's pupil involvement. As a matter of fact, let's just talk about pupil involvement a little bit. Let's say you have a diabetic that comes in with almost complete isolated third nerve. And with bright light, because I already told you and you're already primed now to turn up the lights really bright, there's a little bit of anisocoria. So now you're a little bit worried. One little pearl is that I take that person to the slit lamp right away. And I look for any segmental palsy. Because diabetics often have autonomic neuropathies. And it can affect the pupil either from the diabetes or during the break we were talking about panretinal photocoagulation. That's one way to induce an iatrogenic 80s pupil in diabetic. Because remember the short ciliary nerves, which are the post-ganglionic parasympathetic nerves that are going to the sphincter and accommodation, run right under the suprachoroidal space. And when you're barbecuing the retina from panretinal photocoagulation, you're going to heat up and damage some of those nerves. And it will result in a segmental pupil palsy. I have yet to see an acute pre-ganglionic lesion, like an aneurysm or pituitary apoplexy, that causes a segmental palsy. So all the preganglionics that affect the pupil, like an aneurysm, they affect it circumferentially in an equal way. And so in the case of a diabetic, you think has a complete third, and now you're thinking there's a little bit of pupil involvement, you're getting worried. If you see segmental involvement, it was probably there before. Sometimes asking for a picture or looking at their driver's license with a 20 diopter lens, you might notice that they had an anisocoria before this started. And it'll save you from doing a lot of investigation. It's also very controversial among neuro-ophthalmologists and anybody. What kind of a workup should a cranial nerve palsy get? If it's a complete third nerve and you don't think pupil is involved, and if you survey all the neuro-ophthalmologists in the world, some of them are going to say every third nerve, no matter what, should get imaging studies. And some will say if it's complete and there's no pupil involvement and no other cranial nerve involved, you can wait, warn the patient about watching for pupil involvement and see if it resolves without imaging. But this is controversial and nobody has a right or wrong answer because we're talking about risk-benefit. You're going to image everybody with a cranial nerve, that costs a lot of money. Are you going to make sure you don't miss one single one? So there's no right or wrong answer, but just to let you know that there's not universal agreement among everybody for any cranial nerve palsy. He had an imaging, and there's a finding here that sometimes goes along with ischemic cranial nerve palsies. Do you see anything unusual? So that's the basilar artery. And some people, back in the 1950s, some people would call these fusiform aneurysms, but they're called dolichoectatic basilar arteries. And sometimes they push on the seventh nerve and give a hemifacial spasm. Sometimes they push on the trigeminal nerve and give a trigeminal neuralgia. But they are associated more with ischemic events, whether it's the turbulent flow. And then this patient, he came back, there's the MRA, and completely resolved 3 months later. So this was just an ischemic third. 2 more cases will be done. This was a 17-year-old, and as you can see, the pupil's bigger on that side and the eye's out. And the story was that he's noticed a gradual worsening of double vision over many years. Started when he was playing baseball at the age of 7. And this has gradually been getting worse. And finally, he couldn't deal with it anymore because the double vision came in. So that's the setting, that's the history. And I think it's obvious he has pupil involvement and an exo. And this was his 9 cardinal gazes. So he doesn't get that eye in, right? And he doesn't get that eye up and down either. So how about that history? Huh? Yeah, 10 years, gradual progression, and it's isolated. And he came in with a scan that was said to be normal. But there's the ring sign. Yes, thickening. And so, as Dr. Newman was saying, these are histories that are usually coming with the schwannoma. So the important part of the history, and it's good to back these up with having the parents bring in photographs, is that you see signs of it early on. One fascinating, I've got a couple of these now, where they were myopic in the other eye, and the parents are myopic. But the eye with the schwannoma and the long-standing early in life, is plano. So there's something, whether it's the accommodative fibers or something in the third nerve that prevents an eye from elongating if the genetics and the environment are going to make them myopic. So I'm not suggesting we lesion everybody's third nerve to prevent them from getting myopia, but there's something in there that's controlling axial eye length. This is a case that had a slowly progressive third nerve, but this is a 43-year-old, and the progression was over about 9 months, and it was isolated. Let's look at her photos. Okay, let's start with up gaze. So you draw a line to the limbus, and what do you think? Left eye doesn't get up all the way. And then, if you look at this, it looks like it gets in, but if you compare it to that eye, which I always like to do, besides comparing it to the opposite eye in the same gaze position, I look at how that eye abducts compared to that eye. It does look weak, doesn't it? And then here again, if you drop a horizontal line, this eye's not getting down as much. So a little bit exo. Although there's not much ptosis, but there is a little bit of ptosis if you look at the lid height. And then here's with a pen light, bright light. Because again, if you just looked in clinic light and didn't use the bright light, I don't think you'd appreciate that there's that much of an anti-scoria. It doesn't jump out at you.
But isn't it
Yes, it's hypertrophic. Yeah. Because it doesn't get down either, so it depends on how much it's inferior rectus, but there's some, there's some superior rectus. It's just there's a little bit more inferior rectus, I think. But with bright light, there was an anisocoria, right? So that's the history you should be worried about. It's not an acute pupil involving third, which is a worrisome too, but it's a progressive over 6 to 9 months symptoms, and there's pupil involvement. And so she was imaged, and she had enhancement, but enhancement and thickening. And unfortunately, this was what's called a malignant schwannoma. And she was dead within 6 months. These are highly, highly malignant. So I think the important point is we did that history of the progression, and there's people involvement. That's worrisome.
Did you have any headaches?
No.
Other symptoms?
No other symptoms. I think Afi, is it time? We have a few minutes.
No,
Yeah, it's fine.
I want to show you just a couple quick things.
Yeah, it's okay.
All right. I'm going to take you through this fast, so I don't want to deprive you of your break time too much. I want to talk a little bit about aberrant regeneration of the third nerve and why you should recognize it, because what does it mean? And I'm going to show you some videos real quick to show you. So why is it important? Well, first, it indicates that palsy is not acute. In other words, you have to have damage and then sprouting of axons and regrowth, and they grow into the wrong muscles. So if you see signs of aberrant regeneration, it had whatever was causing the damage had to have been there a little while. And almost always it's due to either compression or trauma. And we'll talk about how you differentiate the two. It obviously reveals that some recovery has occurred because there's reinnervation, but it may be inappropriate, meaning the axons are not going to where they're supposed to be going. And it explains unusual movements of the eyelid, the pupil, or the ocular motility. It also helps formulation of a surgical plan. If there's aberrant regeneration, which muscles, if you're trying to line the person, what you do in terms of resection or recession may make a difference in terms of if there's aberrant regeneration. And the idea is that you have an initial injury, like trauma or compression. You get disruption of not only the axons, but the surrounding sheaths of the Schwann cell. I'll show you a picture in just a second. Remember, these sheaths are like guide wires that surround the nerves. And developmentally, they're a guide that tells the axon, where the axonal growth cone to go to get to the right muscle. And so if you have disruption of the scaffolding that is telling it where to go, then when they're sprouting, it doesn't go down the right guide wire. It's all messed up because there's been damage to that structure. And then the reason you get regeneration of a cranial nerve is that if it's a peripheral nerve, Schwann cells produce nerve growth factor. Oligodendroglia in the central nervous system don't. So that's why with a sixth nerve and a third nerve, after a number of months, you've got growth of the axon from the nerve growth factor that's released, and reinnervation, either normal reinnervation or abnormal reinnervation. And either you get survival of the axons and reinnervation, or they don't make it. They don't find the target, and you have a continued pulse. You might have a mixture. This was from Cajal, beautiful drawings that studied reinnervation of nerves. And basically, these are all sprouting axons from an experimental axon injury. And if you take a stump, from the other side and put it there, it causes all this growth of axons because this is containing the cells that produce the growth factor. And just kind of give you a view, here's the third nerve, and then there's the, fascicles that enclose these different divisions and different axons that go to the different muscles. And those are surrounded by Schwann cells that make this, like I said, a guide wire where the axon's supposed to go. Here's the SEM that I took about 45 years ago to show these axons and the glial cells in between that are, giving these places for them to grow. So a couple rules of aberrant generation. I'm going to show you some quick examples and we'll break. So you have to have denervation before you have sprouting. It's got to be damaged first. You have disruption of the glial scaffolding. That's why in an ischemic third, you would never get aberrant regeneration because you're damaging the axons from ischemia, but the glial structure doesn't get disrupted from the ischemia. It stays there in the right place. So the sprouting you get after an ischemic cranial nerve palsy will always go down the right place. You would never get it because the scaffolding is intact. You have to disrupt the scaffolding to get the axons to go to a different place. And the reinnervation can be normal. Sometimes it completely comes back to the right place, incomplete or aberrant. And another rule is that reinnervation always occurs to the end organ with the right receptor. In other words, nicotinic cholinergic receptors and skeletal nerves go to skeletal muscles, or they can go to smooth muscles if they have cholinergic receptors. So you can have oculomotor nerve that normally goes to a skeletal muscle that's cholinergic. It can go to the sphincter muscle, which is also cholinergic, right? So you would never have an adrenergic nerve go to a cholinergic receptor. That doesn't happen. And the most important point is that people divide these into what's called primary aberrant regeneration and secondary. Secondary means that there was a prior nerve palsy. So the family will say, he was in a motor vehicle accident, he was in bed, and everybody noticed the lid was down. And when the nurse lifted it up, the eye wasn't in the right place. So there was a palsy first. Then months later, the aberrant regeneration came. Primary aberrant regeneration, which is the most important, means you never got a history that there was a palsy. They come in and was the families there? Was there ever any drooping of the eyelid? No. Because the damage in the reinnervation is happening simultaneously, and that's due to compression. So if you get a history of primary aberrant regeneration, there was never a palsy that anybody recognized, that's a big red flag, that there's probably a tumor there, or a chronic aneurysm. And then, just in terms of the signs, we're going to do some quick videos. You've got eyelid signs. I'm going to show you some examples real quick. You've got abnormal ocular motility, and you've got eyelid signs. And you don't have to have all three. So we did a study of about 50 patients with aberrant regeneration, and only about 26%, or a quarter of them, had all three signs of aberrant reinnervation. Most common is pupil and eyelid, and about a little over 50 had both pupil and eyelid. But don't think you have to have all three. And when you look for it, you have to look for one at a time. You have somebody that you think might have it. First look at the lid. Don't pay attention to the motility of the pupil. Then you have to look at the pupil, because your brain can't assess all these things at once. Okay, let's look at eyelid aberrant reinnervation real quick. So you may not see ptosis in primary gaze because something's reinnervating the eyelids. You have to do a maneuver that brings it out. And especially you're looking for the development of asymmetry of the fissures in different gaze positions. So I'm going to show a video in just a second, but here's just a capture from the video. So if you have the inferior rectus nerve reinnervates the levator, then when the person starts to look down, the lid goes up because you're stimulating the inferior rectus fibers that are now going to the lid. If the medial rectus nerves innervate the lid, then whenever the person, tries to adduct the eye compared to abducting the eye, the lid goes up, right? Because again, you're stimulating the medial rectus nerves, but now they're innervating the lid. And then finally, once in a while, the superior rectus nerves will go into the levator. So they don't have any ptosis, and they start to look up, and that lid flies up because the superior rectus is innervated the lid. All right, let's look at a quick couple examples. I know we're getting out of time.
Think of the eye up and look way down. And there's some good difference there. Look way down again. You can't get the eye down very well. I'll have you look down and right. Down and left. Down and right.
So that's the maneuver that's going to bring it out.
Way down and right.
Because you're stimulating both the inferior rectus and the medial rectus. Down and right, down and left. Got it? It's unmistakable. Because normally the normal lid falls, right? Because you're reducing firing to the levator. But in this case, it's just the opposite. Here's one you'll see just in lateral gaze. Watch the difference in the fissure. So when he looks to the right, you get a huge difference. And then this is the one that's not as common when the superior rectus involves the levator. So he's looking down, and the lid symmetry is pretty good. As a matter of fact, if anything, as he starts looking down, the left lid falls more. So the lid's not going up and down gaze. And looking down and right and down and left, it's not really generating a difference in fissure. But watch as I start to gradually bring them up to primary and then beyond primary. Whoop! Now you can see scleral show up there. Motility, least common and maybe subtle. So normally they would have an XT. You're looking for a change in the pattern in up and down gaze. If you have innervation of the medial rectus muscle by any of the superior or inferior divisions, you'll become ET in down gaze or in up gaze. So if the XO becomes a lot less in up or down gaze, or becomes an EZO, think about aberrant regeneration. And this one was really extreme. So when he looks down, that eye goes, to the East Coast. And the last one is the pupil. And I know we're running out of time, so I'm going to show you a video here. So basically, you have denervation of the pupil, so it's going to be an efferent pupil defect. So it's not going to respond very well to light. So you're going to get an anisocoria in bright light. But what's going to happen is the pupil is going to contract on gaze position, either on adduction, introduction, or superduction. Those fibers are now going to parts of the sphincter. So I'm going to show a video in just a second. So you see this one, no anisocoria up gaze or straight ahead gaze, but now you're generating an anisocoria down gaze, right? Okay, let's look at that video, and then we can wrap up. So first we're going to demonstrate that there's an efferent defect with bright light. So in dim light here, there's not much anisocoria, right? As a matter of fact, it's a little bit in darkness. It's the smaller of the two pupils. Think about why that would be. It doesn't react to light very well. Here's the bright light, now you're seeing anisocoria more. Now watch what happens on gaze. See how on adduction now we've produced an anisocoria that goes less on abduction, or going out of the third nerve direction. And watch what happens on other gaze positions. not just happening in up gaze. Now watch what happens on down gaze. And watch when I have her look way down. So you get the idea. And then finally, if you look at the slit lamp, sometimes you'll see this. Some sphincters are stimulated on up gaze and some on down gaze. So you get this weird pattern of constriction. So, so basically you've got these three, signs. You've got the eyelid, you've got the motility, and you've got the pupil. And if you train yourself to look for them one at a time, you'll pick up on it. If you try to look at all three at once, you'll miss it. It's just too much to look at. But the significance is that if they've never had a slap-out third nerve palsy, that's a big red flag when you see aberrant degeneration. That almost always means there's compression. Okay? All right. Sorry to keep you later, but I wanted you to see some of those videos. All right. Thank you.
Thank you so much, Randy, for these days, these lectures. They're really excellent as usual. You're looking scared now, aren't you? We've been trying to slowly introduce you to the Swedish culture. And yesterday we talked about midsummer. And I know how much you love herring. Not. But so you can make some kind of Iowa midsummer festivities. We skip the herring. You can take chicken or whatever you like, but you have to have something to drink for midsummer. So it's
service with everybody at the break.
so you should be able to take that through security because each bottle is less than 100 milliliters. So, and here's an introduction to the Swedish culture and the different things, how we are as a people.
It's been great being here. I really appreciate all of you because you've done such a good job interacting and not being afraid to ask questions. It's excellent. Keep up the good work. You're going to be great ophthalmologists.
Yeah, great teacher.
Thank you.
Are we on? I don't know. No, it's just what I did yesterday. It's good. All right,
Working fine.
I think we're good.
Yeah, perfect.
This is where we left off yesterday, right? You're all experts now on optic neuropathy, and I remember I promised you, we started with a case yesterday, remember? And I had you write down what you thought was the answer, and you don't have to tell me, but now let's go back to that case. So this was that 39-year-old man with vision loss in his right eye to 2200 over 5 days, with a past history of hypertension, no family history of vision loss, and no improvement over the prior 5 weeks. And there is a visual field and his optic nerve appearance. So that was 5 weeks ago. And remember, I'll tell you, he had a normal macula. You're not going to do that to you, right? It's not central serous. And he had a right relative affect pupillary defect, so we know it was a right optic neuropathy, but there were all these choices of all these categories. And so now you're experts, you were before. We know it's not elevated intraocular pressure or intracranial pressure, it's not a toxic nutritional. But I think there are 4 categories that you can at least think about in this man that you might have thought about yesterday. And there they are. You know, he's fairly young. Could this be optic neuritis? Could this be non-arteritic AION? Could it be a compressive lesion? Or could it be Leber's hereditary optic neuropathy? Okay? And just to remind you what things are particularly helpful in that diagnosis is, you know, in general, optic neuritis and Leber's are in younger patients, and in general, optic neuritis is more female and Leber's more male. One of the absolute key things is this. You really are at your peril to make the diagnosis of optic neuritis without some discomfort. It's an itis. It's painful. And then if you still don't know, you can get the MRI, but make sure it's the MRI of the orbits with fat suppression and gadolinium. And then if you still don't know, you can wait, and optic neuritis should always get better. So in this man, think about where we are with him. And if it's not enough for a few of you, I'll tell you that he has a normal MRI of his orbits. And he had no vision recovery in that right eye when you saw him at 5 weeks. And indeed, he had no vision recovery in that right eye and no involvement of the left eye for more than 1 year. So I think I'm making it a little easier for you. But some of you got it right from the get-go, and some of you got it after yesterday's lectures, and maybe some of you got it when you saw this, but I'm sure everybody got it, right? So he had a non-arteritic anterior ischemic optic neuropathy. So pat yourselves on the back. And now, here we go with things that are not so straightforward. Yes, sir?
I think in this case, a very important point is the optic disc and the contralateral eye,
Yes.
which is a disc at rest.
Correct.
It really confirms the diagnosis.
Right. It allows you to make the diagnosis, but be careful. There are millions of people who have a small crowded nerve who are also allowed to have optic neuritis and allowed to have compressive lesions. But you are at your peril of making the diagnosis of non-arteritic anterior ischemic optic neuropathy unless you see the disc at risk on the other side. So this allowed it to be in the differential, and it turned out to be the actual result. Great. Okay. So are we ready? I think we'll fit one in before the big coffee break when you all have to check out. And then don't worry, we'll fit it all in. I'm going to cut into their time. Okay. So this is a 41-year-old woman with bilateral vision loss. She was well until 1 year earlier. Okay, so we're talking maybe even before some of you were born, but that's okay. So in June of 1992, she had some numbness and tingling of her extremities and some paresthesias in her perineal region. She had an MRI at the time and visual evoked responses which were normal. 3 months later, she noticed an obscuration of vision in her right eye. She sees an eye care professional who notes 20/20 vision in both eyes and tells her that it's a floater in her right eye. However, by December, she's 2200 in that right eye, 20/20 in the left. She has a right relative afferent pupillary defect. She has another MRI and a lumbar puncture. They're normal. She's treated with IV steroids for presumed optic neuritis and multiple sclerosis. In April of 93, she notes a blind spot in the vision in her left eye. She's now count fingers in the right eye. She's 20/30 in the left eye. She still has a right relative afferent pupillary defect with right optic disc pallor. And again, she's treated with IV steroids with no effect. And these are the fundoscopic appearance at that time with pallor of the right optic nerve and a normal appearing left optic nerve. And here is the visual field of her right optic nerve at that time. And here's the visual field of her left optic nerve. And the key here is don't just look at the place where everyone says, put your coffee cup. You need to look over here at the pattern deviation. And so she's got a little something happening centrally in the left eye, and she was noticing it. And by the time she sees you in June of 1993, about a year after she has started to have any symptoms at all, about 9 months after the first eye, the right eye, was definitely involved by something. She's now count fingers right eye, 2300 left eye. She has a right relative afferent pupillary defect, and now she has bilateral disc pallor. And here are her fields. So she has central scotoma in the right eye and what looks like a supratemporal defect in the left eye, but we know it's got to involve fixation because she's 2300 in that eye. Now, if you just looked at this, where would you localize the lesion? Yeah, this is what so-called junctional scotoma would be the most posterior right optic nerve and chiasm. But the fact that the vision, central vision is involved, and let me show you. So we had, remember this was the field we saw first, then it became this, and then it became this, with some central involvement, which is what we have here. So junctional scotoma gets you scared again. Maybe we missed something compressive, right? So I will tell you her repeat MRI was completely normal. So folks, what you got? She's a woman. She's a woman, she's 41. Don't get there. Don't get there. You're right. Stick with it. She's positive for the 117. Good for you. Good for you. And this is really excellent. That's exactly what it is. And that's, you have to, even the atypical cases. So the take-home message, she was positive for the 11778. Take-home message, think about labor hereditary optic neuropathy in any patient with bilateral, painless optic neuropathies, no matter which gender and what age. Yes?
It changed again in 1 year, yeah?
Yes.
That was the reason.
That's another clue. Although, of course, optic neuritis would have been within 1 year,
yes,
too, if that were what it is. And people were swearing back and forth that she had multiple sclerosis, despite negative MRI. So, very, very good. you're gonna find it easy. We're gonna get to another case then before the break. You're too good. All right. He's a 47-year-old African-American man with decreased vision in both eyes. So his past medical history, so he's HIV positive, diagnosed in March of 2004. He uses cigarettes, but not alcohol. He's on the antiretroviral cocktail for his HIV. His family history is notable for hypertension, diabetes, and glaucoma in his mother. And he's a high myope. He's never been correctable to 20/20 as far as he knows. He's been followed by an optometrist, and 3 years prior to all this, the optometrist actually told him that he had glaucomatous optic nerves. His mother was also not correctable to 20/20, and he had always passed his driver's test. But in December of 2004, just like a few months before this, so what did we say, he was 47? So in December of 2004, he actually failed his driver's test, but he had last passed it 10 years prior. So we don't have to take them every year in the States. It's usually when you renew. So we know that sometime within 10 years, between the age of 37 and 47, he went over the line of the driver's test, which in most states, and in this state we're talking about here, is 20/60 vision in at least one eye. So, you see him in March of 2005. So it's a year after his HIV diagnosis. He's been on the antiretroviral drugs for that time, and he failed his driver's test about 4 months before. And he's 20/70 minus 2 in the right eye, 2400 in the left eye. He sees the control color plate only in the right and no control in the left. He has a 0.6 log unit left relative afferent pupillary defect. His motility is normal, his slit lamp is normal. He's on no glaucoma medications, and his intraocular pressures are 12 in both eyes. And these are his visual fields. Is this glaucoma?
No, it's certainly
No.
Bothers me for glaucoma. And here are his discs. Now, they're pretty big cups. And there's nasalization of the vessels. And the cup in the right eye is kind of vertical cup, isn't it? Kind of thing you see in glaucoma. The rim, is it pink or pale? Hard to tell when it's that little. So, yikes. We know we've got bilateral optic neuropathies, or we wouldn't be showing this case, right? Everybody's on the page with that. This is not a retinal disease. Bilateral optic neuropathy. So let's look at the categories. I think there are a few you could toss out. We don't have trauma, we don't have elevated intracranial pressure. I think everybody's good with that, but there are a whole lot of other things there. And then the course probably doesn't suggest vascular, and he sure doesn't have dis at risk, right? But we're left with a bunch of others. So could this be elevated intraocular pressure? Something to at least keep in mind, but he's got IOPs of 12, his mother had glaucoma, we think, right? Okay, what do we absolutely have to rule out? We've got a progressive bilateral optic neuropathy. What does he not have? Right, compressive infiltrated. So we really have to take care of that, but that's easy, we can take care of that. So his MRI is completely unremarkable. He's got a few non-specific tinsels. So we don't think we've been able to rule out compressive. So which other category?
Parasitory.
Toxic metabolic. Okay, so toxic nutritional metabolic. So we better